have been coming to CSCO for 15 to 20 years as a guest of Professor Ma Jun. And it began maybe 18 years ago or so when CSCO, in collaboration with Professor Ma Jun and the T-Cell Lymphoma Forum, which I co-chair with Drs. Foss and Kim, we put on a satellite symposium here associated with CSCO, where we brought select speakers from the T-Cell Lymphoma Forum to China, and we had a half-day meeting devoted to the disease. I think that is one of the great examples of the importance of meetings like CSCO. Over the years, we've read a lot about the partnerships between CSCO and ASH and ASCO and boutique meetings like the T-Cell Lymphoma Forum, as well as with the other European meetings. And I think cancer is not a problem of any one country. It's a global problem. And patients share the same needs no matter where they live. And I think meetings like CSCO and the international collaborations forged by meetings like CSCO and other venues around the world create a dialogue where doctors can share ideas, insights into the development of different therapies so we can pick and define what's the best treatment for our patients. So probably the most important basis or reason behind a meeting such as CSCO is to forge global collaborations around the problem of cancer. Your cancer conjures something of a disappointing response in that we have seen major progress in the development of small molecules, precision-targeted drugs, monoclonal antibodies and various bispecifics, antibody-drug conjugates, and CAR-T. These therapies have changed the landscape of virtually every disease across hematologic malignancies, except the T-cell lymphomas. Probably the one advance that has occurred that has led to some practice-changing impact has been the development of the antibody-drug conjugate brentuximab vedotin in combination with CHOP-based chemotherapy was shown to improve the survival of patients with anaplastic large cell lymphoma. Really, aside from that, many of the developments that have had such huge impact in other areas of blood cancer have not had the same degree of impact in the treatment of T-cell lymphoma. I say that despite what I think is the new emerging targeted treatment, which is this biologic focus now on the epigenetic dysregulation in the disease. Just here recently in China, you have approved a drug formerly known as SHR-2554, an EZH2 inhibitor that was studied in a trial by Dr. Song. EZH2 inhibitor is yet another example of an epigenetic targeted drug. Here in China, you have a HDAC inhibitor called chitamide that was approved. There are now 4 HDAC inhibitors approved around the world, and we now know that drugs targeting DNA methylation are also extremely potent. What's becoming now really clear is that combinations of these epigenetic targeted drugs are producing results that we haven't seen with conventional chemotherapy or other targeted drug combinations. And I think that's because it's targeting what I see as a unique vulnerability in the disease, this dysregulation of epigenetic biology. And of course, when we think about cancer biology, probably there's no biology more complex when you're thinking about cancer cells than the epigenetic dysregulation. We're just scratching the surface in our ability to understand it. We're scratching the surface, in my opinion, on just beginning to target it. But if there is a promising clue, it's something we need to oblige and follow. It's to begin thinking about how to rationally develop combinatorial therapies of epigenetic drugs, either in combination with other targeted drugs, chemotherapy, or biologics. But for me, that's the clearest biologic signal we've seen ever in the disease. And I think you here in China, with the approval of your EZH2 inhibitor, the approval of your HDAC inhibitor, and other drugs in this area, are sitting poised to help lead the way in trying to understand how to use these drugs in collaboration with others around the world. Probably one of the most important is a consensus around pathology. And over the years, the pathology or pathologic diagnosis of T-cell lymphoma has been complicated and evolving. And the World Health Organization has put together the classification of hematopoietic malignancies, including the T-cell lymphomas. And there's a significant focus on trying to understand the biologic basis of these different types of disease and to try to understand the classification. So probably, while we don't yet have therapies that are unique to specific subtypes of T-cell lymphoma, save the development of treatments for anaplastic large cell lymphoma or some of the NK nasal type T-cell lymphomas. Most of these diseases, we don't have subtype defined treatment paradigms. So the first step is to just get the diagnosis right. And that's not so easy, because just as you seek treating physicians that have experience managing the disease, you gotta trust that those physicians have pathologists at their side that are familiar with the pathologic diagnosis. Because if we're going to be able to get it right in terms of differentiating these diseases and then beginning to tailor treatment for the disease at large or specific subtypes, the treating medical oncologist or hematologist has to be very confident in the pathologic diagnosis. So I would argue that a strong pathologist support system to help the team, including the medical oncologists, make decisions about treatment is incredibly important.